All right, I think we can go ahead. So hello everyone, and thanks for joining Getting Ahead of Denial, Simple Fixes for Smarter Coding. My name is Jordan Leibovitz. I'm part of the marketing team here at IMO Health. Before we get started, a few housekeeping items for you. First off, we are recording this webinar. It will be sent to you later in the week, so look out it for in your inbox. If you have any questions while our speakers are speaking, just type them into your Zoom webinar console under Q&A, and then once we wrap up the presentation, we'll do Q&A. So today we have my lovely colleagues from IMO Health, Samantha Lineberry. She is our Director of Product Management at IMO Health, along with Sarah Schultz. She is our Product Sales Specialist at IMO Health. So with all this being said, I'm going to have Samantha take it away.
Hi, everyone. I want to give everyone a little background on IMO Health and let you know who we are. IMO Health enables clinical data quality, making data more useful and valuable across the healthcare ecosystem. For the last 3 decades, IMO Health has powered data capture at the point of care with comprehensive clinical terminology and code mappings that allow clinicians to document in their own words while capturing the necessary clinical detail and billing codes behind the scenes. IMO Health's terminology is integrated into clinical workflows of all the major EHR vendors, including Epic, Oracle, Meditech, NextGen, Greenway, NetSmart, and many more. We deliver the industry-leading foundation of clinically vetted terminology that's always current and meticulously mapped to the right codes behind the scenes. We're experts in the words and codes that describe patient conditions and treatments, from diagnosis to surgeries, labs, and medications. At IMO Health, we have a team of expert clinical terminologists that monitor and maintain terms and codes to keep up with all regulatory coding systems such as ICD-10, SNOMED, CPT, RxNorm, LOINC, and many more. This allows our clients to confidently meet changing regulatory reporting requirements. That's a little about us. So this is what we really want to talk to you guys about today, the denial challenge. Over $260 billion lost annually due to denied claims. So today's webinar will focus on the financial impact of claim denials and how structured coding and documentation practices can drive better outcomes. We'll explore together practical in-workflow solutions that can improve coding accuracy. They'll reduce denials and deliver a measurable ROI, or return on investment, without relying on complex technology. You'll also hear real-world results from organizations like you that have significantly improved reimbursement and compliance. So let's dive in. Coding rules. What are coding rules? Coding rules are structured guidelines like ICD-10 coding conventions, sequencing instructions, and CMS guidelines that govern how diagnosis and procedures are reported. Some examples of coding rules are the code first rule, code also, excludes one, code to the highest level of specificity, including laterality, left, right, or bilateral. So how do these rules impact coding? Regulatory compliance. Adhering to ICD-10 coding guidelines is mandatory for billing and reimbursement processes. Data quality. Consistent application of coding rules enhances your data accuracy, supporting better analytics and improved patient outcomes. Reimbursement and value-based care. Precise coding ensures proper claim submission, reimbursement, and it also plays a critical role in your value-based care models. So, importance of documentation at the encounter level and downstream. So we have several items here that shows how important it is to document. Coding specificity and accuracy is an encounter level impact. Precise documentation supports accurate coding, which improves understanding of the patient's condition and informs treatment decisions. You want your provider to make sure they're documenting as specific as possible to ensure that the diagnosis that your patient receives is accurate and that you're able to provide them with the highest level of care. Care coordination. Well-documented encounters enhance communication across care teams, supporting better coordination and continuity of care. With that accuracy of diagnosing and coding, you make sure that when you're sending those folks to another level of care, when you're sharing this information to get lab results, when you're trying to order procedures for them, that you're capturing that clinical intent with your diagnosis accuracy. Some of the downstream impacts are value-based care reimbursement. Accurate documentation ensures providers are fairly reimbursed for the care that they deliver, especially under a value-based care model. Documentation must align with coding guidelines, particularly for Medicare Advantage plans. Where HCCs or hierarchical condition categories adjust payments based on documented patient conditions and complex needs. Claim edits are applied more aggressively, with Medicare Advantage plans scrutinizing your documentation for coding errors. Compliance and audit readiness is another downstream effect. Thorough documentation supports financial integrity. It prepares organizations for audits. Complete documentation mitigates liability and protects the patient and the provider. Precise documentation also supports medical necessity and prior auth, as well as analytics and reporting downstream. So next up, we have a poll question for everyone. What is the most common reason for denied claims at your organization? Is it code first or primary code errors? Conflicting diagnosis codes such as excludes one pairings? Unspecified laterality or medical necessity denials? We'll give everyone a little bit of time to answer these questions.
All right, let's see. So it looks like most people are picking medical necessity denials and conflicting diagnosis codes.
Wow, so we've heard this a lot, and we've got some great things coming from IMO Health, so we're excited to kind of discuss those soon. And so for our next poll question, what challenges do you guys face most often when dealing with denied claims? Do you have a lack of staff or resources, provider coding errors, limited budget for third-party solutions, or physician workflow disruptions such as queries?
Give it a few more seconds. All right, it's kind of an even toss between lack of staff and resources, provider coding errors, and then also workflow disruptions.
Wow, we've heard this a lot. So, this is falling right into place with everything that we've heard in the market since we've been building out solutions. So, as we dive deeper into the root causes of claim denials, it's important to recognize the growing complexity of coding guidelines and how they're contributing to an unsustainable cycle for revenue cycle teams. Let's start with the challenge. Health systems are seeing a high volume of denied claims, often triggered by issues like unacceptable principal diagnosis and unspecified laterality. These aren't just minor errors, they lead to significant rework, often by coders and providers. Teams are spending valuable time clarifying clinical details, correcting codes, and then resubmitting claims. Unfortunately, when those claims can't be fixed in time or they're not a high cost claim, they're often resulting in write-offs directly impacting revenue to that system. Now, how do we mitigate this? The key is to improve coding accuracy from the start, right at the moment of documentation. By embedding smarter tools and workflows, we can prevent data quality issues before they reach billing. This not only reduces denials and lost revenue, but it also minimizes the burden on clinicians and coders. Importantly, we're not talking about overhauling your system. We're talking about leveraging the tools that you already have to make meaningful improvements. This approach helps reduce return to provider queries, streamlines your documentation, and ultimately reduces denials and rework. So what's contributing to the high volume of denials? Let's break down the specific coding issues that are driving these. Non-primary codes used in the primary position. These codes are not valid as principal diagnosis, like manifestation codes, external cause codes, SDOH codes. When these are used incorrectly, particularly in your Medicare Advantage claims, they're flagged and often denied. So we need to proactively identify these before the claims go out the door. Unspecified codes. So CMS and other payers are increasingly requiring additional specificity. Codes that lack laterality or detail, like unspecified knee pain, can trigger a denial. So it's critical to identify these and correct them during documentation, not after claim submission. Excludes one code pairing. So these are mutually exclusive codes that can't appear together on a claim. For example, sore throat and tonsillitis. These conflicts are often missed when providers aren't trained on coding rules, and it leads to costly denials. Each of these issues is preventable, but only if we surface them early within the provider workflow, and that's where our coding intelligence solution and our terminology-driven nudges can make a real impact. One thing that we've found is a lot of times with exclude one errors, a patient comes into the doctor with a sore throat. That's the first thing that gets added to that encounter. And then later on, that provider determines, after lab testing and other interventions, that that patient has tonsillitis or strep throat or whatever. And they add that code at that time. Well, they don't remove the initial code that's less specific. So that's what causes a lot of these errors. But we're looking to try to figure out how can we intervene and get those corrected before these claims go out the door. So our next poll question, interestingly enough, we're seeing more and more clients coming to us saying that they have a medical necessity challenge. So let's uncover why. Are most of your medical necessity denials coming from private payer claim edits, your Medicare Advantage or Medicaid payers, your commercial plans, or are they coming from NCDs or LCDs, your national coverage determination and your local coverage determination?
Giving it a few more seconds and okay, it looks like private payer claims edit.
Wow, that's great to hear. That's actually one of the focuses of some new products that we're working on right now. So excited to learn more about where you guys are having pain at currently and then how we can help address those in the future. So rethinking solutions that you don't need complex AI to see impact. Coding intelligence doesn't require complex AI or disruptive system overhauls. Instead, it leverages IMO Health's curated value set content and it integrates seamlessly into your existing EHR provider workflow. As providers are closing their encounters, real-time nudges flag problematic codes such as unspecified laterality and inappropriate primary diagnoses, and they provide detailed messages on how to correct those issues or choose a better alternative before they reach billing. So the quick implementation is fast and easy setup with minimal disruption in the workflow. Rapid results, our customers are reporting at minimum a 67% reduction in coding errors within 30 days of their implementation. Built-in education. So providers appreciate the in-workflow guidance, which improves their coding literacy by reinforcing coding guidelines during documentation. Many of our providers have told us, I never chose laterality because I didn't know I had to. Or maybe they didn't choose, they didn't know they couldn't choose a manifestation code as a primary code. They just assumed that it was okay because they didn't get that training like coders did. So this is a great tool to kind of improve their coding literacy and reinforce coding guidelines. So now I'll pass it over to Sarah Schultz, who will provide some insights into how to address these challenges at the point of care.
Thanks, Samantha. Yeah, so we at IMO have been working with our clients for the past few years to try and address some of these issues. Ones that we hear about commonly, like Samantha mentioned, are these problem-based denials, specifically providers selecting non-primary codes as their primary diagnoses or unspecified codes. These exclude one conflicts on claims. So those redundant codes, things like tonsillitis and sore throat that are mutually exclusive and shouldn't be billed together. And then we often hear about medical necessity as well. And we typically see our customers really taking one of two approaches. On the next slide, we'll kind of see a few of the different ways people approach this. So what we've seen is really an effort to either move the identification of these inappropriate diagnoses as far upstream as possible in front of your providers, which that method is valuable in the sense that you're correcting the documentation at the point of care. So you're doing that all before you close an encounter, before it goes downstream and becomes a burden on your revenue cycle teams. Sometimes we hear that people, worry about putting alerts in front of providers. Something that we've seen that's really important with these provider-facing alerts is that you can't just tell them when they're using a diagnosis that they shouldn't be using. You really need to give them guidance on what they should be selecting as a better alternative. And really what we've seen people doing in the past is you're busy, your coders are busy, your rev cycle teams are busy, and they don't really have time to maybe make complete lists of every code that could possibly be denied for any of these reasons. But you know what you're being denied on most frequently, and people kind of keep short lists of their most common denials, and then they use those lists of references to either check if a provider is in an encounter and they're selecting a primary diagnosis, is that an appropriate code or does it fall on that list? Or they'll check it once it's in the rev cycle solution. One thing that we've been helping out with that Samantha alluded to, our coding intelligence solution, is we've really taken the identification of those lists of codes and then also all of the maintenance burden of maintaining accurate and up-to-date ICD-10 codes. And we're curating those value sets and lists and providing them to our customers so that they can be used throughout your system, and you don't have the burden of maintenance and the creation of those. So we typically see when people are using these upstream workflows, they'll put checks at either when you're going to close the encounter. So after you've documented all your visit diagnoses, and they'll compare the primary diagnoses to our content, or they'll do it when at order entry. So when they're placing orders to make sure that the diagnosis associated with the order is appropriate. And then on kind of the other side of the house, some choose to use this in work queues and revenue cycle workflows. So using these lists of codes to really identify inappropriate diagnoses on charges and claims and allow their revenue cycle teams to correct them. And then we can kind of show you some examples of what these alerts can look like and the content we provide in action. So if we go to the next slide, so you can see here a handful of examples of alerts that our customers use driven off of this content that we provide. So these particular examples are from an Epic customer. So they're using that EHR, and then this is kind of an example of what a closed encounter validation message looks like for them. So after a provider's finished charting and they're closing the encounter, it will check for a series of validations to make sure that the encounter is ready to flow through downstream workflows. And you can customize the list of checks. So what you can do is you can say what primary diagnosis is currently selected, and then you can compare that to IMO's content. And something kind of unique about our content is that we don't just give you the ability to identify whether something is a non-primary code or whether it's an unspecified code. We actually have a whole team of clinicians clinical terminology experts, and then also mappers in-house. And what they do is they look at these larger umbrellas of codes and the buckets they fall into, unspecified, non-primary. And then they take the time to go and really break them down into finer groupers. And the reason that's important is because those groups of codes, those value sets, they're refined enough that we can tell you if a non-primary code is non-primary because it's an external cause code, or it's a manifestation code, or a complication, if it's unspecified because it's missing laterality, or for some other reason. And that's how we're able to surface some of the more specific messages you see on the screen. So the one that has the red stop sign on it, that's configured as what's called like a hard stop. It's the provider there is using fall from bicycle as their primary diagnosis. And we're able to tell that that's an external cause code with our content. And then we can surface a message that says, please use the injury or problem as the diagnosis rather than the cause of the injury or problem. So that's a bit more helpful than us just telling them that that's a non-billable code and something they shouldn't be using. It really gives them context around why they can't be using that so that they can go make a better selection. And then the other really benefit to some of these really specific slices of codes is that it teaches people patterns. And that's something we hear about regularly, especially from institutions that have a large amount of residents. When you're straight out of med school, you're not really familiar with coding in general, and you're very focused on the clinical aspect, as you should be. But they can struggle, especially, and we've heard from them that they really like this because when they place a code that they shouldn't be placing, they don't want it to go downstream and end up with late payment or partial reimbursement. And this way they can get a message up front that tells them exactly why they can't be it going forward, usually using a subset of diagnoses so they quickly learn what they can't use. And particularly things like fall from bicycle. If you can't use that, you can't use fall from anything. So it's a helpful training tool. And these end users can actually, once they start getting these alerts, see less and less over time because they are learning from them. And then I see, so there's a question in the chat. Are your responses payer specific or all based on CMS allowable diagnoses? So we provide content on our website that is based on the CMS allowable diagnoses, but we do also have the ability to create custom payer-specific content as well. So it's kind of two-prong. If you decided to, you can get the CMS allowable diagnoses by just hitting download. And then if you had a payer that deviated from that, we can work with you to create custom content for your organization and any organization that's using that same payer in the same region with the same plan. And then one thing we have noticed though is, so we have quite a few customers using this solution. A lot of times people will ask us about payer specific groupers. And they'll start with the CMS allowable diagnoses. And for the most part, they don't actually find a need for the payer-specific groupers or value sets, depending on what EHR you're using, different terminology. And they don't actually need to make that extra step. And then, yeah, so just looking at some of the other examples on here. So we kind of saw that external cause example. You can see we have the unspecified laterality, history terms, and then inappropriate obstetric terms as examples on here. And you can see, if we're seeing that you're using a weeks of gestation type of diagnosis, we can also tell you that you need to be using the obstetric issue you're addressing or a certain type of encounter. So these are just 4 examples of the groupers that we provide. We actually provide 19 different slices of the non-primary kind of umbrella of codes on the outpatient side. We also provide inpatient content for non-primary codes. And then on the unspecified side of the house, beyond laterality, we also provide a few other groupers, things like pathogen codes. So those instances where you are using a diagnosis, something like pneumonia, technically you need to be specifying the pathogen for that to be fully specified. It's not always easy to do that. So the nice thing about us splitting them out too, choose what value sets you use as checks. So if there's certain ones that you decide for your organization are not as helpful in a provider facing alert, you can either just use them in your coder workflows or you don't have to use it at all. Typically, you can specify if something is just a warning. So it will let end users know that they should be correcting something, but it won't make them do it. Other organizations choose to make things required stops. So a physician actually has to correct the code before they can close out the encounter. So it's very flexible. And typically too, you also have the ability to tweak these messages that they see. So if you don't like if you want to make little customizations, you don't want the exact language that we provide in our messages, you can also edit that. And then if we go to the next slide, I can kind of put some context behind all this. So we started working on this solution several years ago, and it started out as actually a customer request. And I think that really speaks to why it's been so, it's resonated really with our audience. And it's a problem that a lot of organizations have. So we started on that a few years ago, building out groupers, and we started with 2, and we've essentially just added more and more over time, and we're always adding more and more to increase the value that we're providing to our customers. And one of the groups we worked with early on to just make sure that the groupers we were making were targeted enough that the end user messages were actually actionable and made sense to providers was Metro Health in the Cleveland, Ohio area. Outpatient setting visits. So they put it in front of providers. And within a month, they saw a 67% reduction in the amount of these unacceptable primaries that their providers were putting on encounters. And so for them, that's saved them about 2,200 hours of coding time in their first year. So that's about 1 full-time employee that they can put on a lot higher value claim work. Yeah. And then if we go to the next one too, this is another customer who we helped implement these alerts. So they were a smaller organization. So they had a limited sized coding team. So some of these alerts were really burdensome to them. When they implemented these alerts within their first month, they saw a 71% reduction in the use of unspecified laterality codes on their encounters, and then a 54% reduction in non-primary codes. So you see, we pretty consistently get about 70% reductions. And then we'll go to the next one, Samantha. This is kind of changing tune a little bit. So the first part, we were really focusing more on those non-primary and unspecified codes. This slide is really talking to that exclude one conflicting diagnosis issue that we discussed earlier. So we additionally provide content that can help you identify claims that have conflicting diagnoses on them. We've heard that this has become, especially recently, a very big issue for some of our customers. One organization that we work with was seeing about $5 million in denials a month because of those conflicting codes. So we also provide content that basically goes through the CMS book, like the code edits, and it will give you in a more granular fashion the used with, and we can help you implement that in your system logic to help you identify these fully and accurately. We typically see people put this in a coder workflow. You can have a clinician facing alert and ask them to select, remove a diagnosis, but typically what we see is people will put these in work queues and have their coders work it. But with our content, it can speed up the process because we're able to identify everything, and then we're able to tell you which two codes are conflicting as well. So a coder can quickly see at a glance which codes on the claim are conflicting, if there are more than two pairs of conflicting codes, and then they can quickly go through and remove whatever they deem appropriate. And then one other thing we wanted to show you, a couple things on the next slide. This is a example of how we do ROI evaluations for our clients with this solution. So one nice thing about this is that it does have a hard ROI associated with it, because we can report on the frequency with which you are using like unappropriate diagnoses on encounters. So we can actually help you guys take reports of your own data and kind of do a health check and see how frequently your providers are using these unacceptable primaries. And then with that information, we can do some estimates just with industry standard values to give you a dollar amount. The nice thing about this too is this being an easy to report on solution is that we're able to easily look at before and after results. So kind of those results we showed you earlier from Metro Health and Portland Clinic, and this Metro Health again, but those percentages of reduction are actually from these polls. So what we typically do with our clients is we'll take a poll pre-sales, and that can help you understand, how extensive of an issue this is for you before you invest in a solution. And then we also have that so that when we take a post-live poll, we can do a comparison and see how much improvement you've had. We typically do our first poll within a month of go live, because the solution, you really quickly see results as soon as you turn it on. You start seeing results. So it's a pretty short duration of time between when we can take that first look. And then what we do is we analyze that, we present the results, and then we also present any recommendations we have for tweaking things that might benefit your organization. And we can get as specific as department by department. So that can help you make decisions. A lot of people, want to do maybe a hard stop and force their providers to correct like an unspecified laterality diagnosis if they are working in the orthopedics department, but then in a different department, they might not find that as appropriate. So we can help kind of consult on all of that. So here in this slide, you can kind of see an organization that's, a mid-sized Midwestern organization like Metro Health. They're seeing about 800 claims in a month that have unspecified or a laterality or non-primary codes, which is just a fraction of the content that we provide. And we're able to kind of project that they'd save about 900,000 annually. And then just one more example of that on the next slide. You can see here kind of just another example. So this is a much higher volume organization with a higher ROI. And what we see too is that as organization size increases, ROI does as well. And then this also includes our unspecified content in addition to increases the ROI. So if any of you would be interested in having this type of analysis done on your organization's data, to see how you're doing and how much of an issue this is for you, this is a complementary data analysis. So if you were interested, you can just contact your contact at IMO or me or Samantha, and we can get in contact with you guys to help you create a similar projection. And then I think we have time for questions.
Yeah, so at this time, if you have any questions, just type them into the questions section. There are a few that came in. Does your solution provide evidence-based content to drive clinical decision support alerts when a procedure is ordered with an inappropriate diagnosis selection?
Yeah, so I'll take this one. We currently don't have that content completely built out and available to support those type of connections, but we're actively developing a medical necessity solution at this time. And this is going to initially focus on those private payer policy rules. So I think in one of the poll questions earlier, you guys alluded to the private payer policy rules being a challenge for you with medical necessity. And that's what we've heard across all of our customer base and folks that we've been talking to. So we'll initially focus on that private payer policy rules with plans to expand to NCDs and LCDs over time. Um, Everybody is interested in how we're going to build this solution out. We're exploring innovative approaches to address it. If you or anyone in the audience is open to meeting with us to share your challenges, to offer feedback on early concepts, we would greatly value the opportunity to connect with you. So feel free to reach out, email me or Sarah after the session if you're interested. And we would love to hear like what your pain points are around medical necessity and those CPT and ICD-10 issues that you're experiencing.
Okay. Another came in, does this help with fraud and abuse?
Yeah, I'll take this one too. So, ensuring compliance and preventing fraud and abuse really starts with precise, high specificity documentation. This level of detail not only meets regulatory requirements, but it also clearly demonstrates that you're providing medically necessary care, you're helping providers align with industry quality standards. So, accurate documentation supports appropriate coding by clearly justifying that services are rendered appropriately. You minimize the risk of upcoding or unbundling procedures that should be reported together. And you're capturing that detailed clinical information, and providers can reduce any discrepancies and lower their audit risk by using our detailed terminology. Our solutions are built to support this level of specificity at the point of care by empowering clinicians to document with clarity and confidence. We align clinical language with coding standards, and we help safeguard against improper payments to promote accurate reimbursement and reinforce both compliance and care integrity.
Nice. Final one. How do you prevent over alerting?
Yeah, I can take this. So when we're designing our content, we're really cognizant of the fact that these could be used in a workflow that's presented to clinicians. So our clinical team goes through and really thinks about what diagnoses these should fire on. So there are certain things that like we do not recommend necessarily implementing a physician-facing alert for, or if you do, we recommend that you put it in as a warning. And when we help our customers implement these solutions, we're very hands-on and we give all that guidance. So like an example of that would be something like fever. Like fever is unspecified, but it's very difficult to give an example of like what's causing the fever in an initial encounter. So it's hard to get to a specified diagnosis, and that just doesn't make sense to alert a clinician on, especially because that's a common diagnosis that you'd be using. So that would just be unnecessarily obtrusive to them. So we don't put that in a grouper that we would have an alert based on. So we're cognizant of that. We make sure that we take that all into account as we build out our content. And then we also always work with our customers and take feedback from them as well. So if there's something that maybe less obvious than fever that we thought was appropriate to include, but maybe others don't agree, we're always willing to revise and take that feedback into account.
Okay, a few more came in. How often does the IMO tool update its system to reflect changes on ICD-10 guidelines?
I can take that one. So we actually update our content 5 to 6 times per year. So anytime, there's ICD-10 updates that come out, regulatory updates, any changes to Medicare code edits or any of the guidelines that we follow, we will update our content for that, and we push those updates out with our core updates 5 to 6 times per year.
Awesome. Another came in. Do you have any workflows related to authorization/referrals to alert front-end users in real time at check-in or appointment level workflows?
So we don't currently have any workflows related to authorizations or referrals at this time, but that is some of the ideas that we have been tossing around with some of our new revenue cycle solutions. So love to hear your feedback and understand, what the pain points are you're currently experiencing and how we could possibly help. So feel free to email us or reach out if you want to discuss live.
Okay, I think that is it for questions. Samantha, do you want to go to the next slide? I know you have your emails on there.
Yep.
Awesome. So thank you so much. Thanks, Samantha and Sarah, for doing this. You guys did great. Thank you to our lovely audience for joining. I know you have a lot of other places that you can be right now, so thanks for spending your lunchtime with us. If you have any questions regarding IMO Solutions, just email sales@imohealth.com. This is another update that we have a webinar coming September 11th. It is our 2026 ICD-10 update on the code set release. We do this webinar every year. It's our most popular webinar of the year. So you can visit us at imohealth.com/events and just register there. And I hope to see you there. With all this being said, I think we're going to go ahead and close out. Thank you.
Thank you all so much for joining.